Namaste. Now I am going to speak about assessment of anxiety, depression and distress in patients who are on palliative care. The faculty for this topic is Dr. Piyush Mahajan. He is MD in Psychiatry. He is a senior resident at Department of Psychiatry, Sri Guru Ramdas University of Health Sciences, Amritsar. This lecture will contain the introduction of the topic, then how to assess the psychological distress in terminally ill patients, assessing the depression in terminally ill and assessing anxiety in terminally ill, and there will be conclusion of the topic. Psychological distress, anxiety and depression often causes suffering in terminally ill patients and poses challenges to the diagnosis. For assessing the psychological distress in terminally ill, we use distress thermometer. It has got a scale from 0 to 10. 0 means no distress and 10 means extreme distress. And patient is asked, during past week how distressed you have been. So, he has to mark a number on this scale, whether it is number 4, whether it is 7, whether it is 8 or whether it is 10. And if it shows distress, then which area or which problems is giving him distress, that we try to find out from the list which is given besides the distress thermometer. Is it the distress is because of the practical problems like housing, insurance, work, school, transportation, child care? Is it because of the family problem? Is it because of the emotional problem that patient is worried, sad, depressed or nervous? Or is it because of the spiritual problem that he is complaining to the God that why I am suffering, what type of wrong thing I have done in my life that I am suffering? Or it is because of the physical problem like pain, nausea, vomiting, not able to sleep, not able to eat, indigestion, constipation and many physical problems. So, this is the brief screening tool and with the list of problem. So, by ticking this list of problem, you can find out that which are the problem which is causing distress to this patient. At least 2 of the following 3 symptoms must be present in the patient. Patient should have depressed mood to a degree that is definitely abnormal for the individual, present for most of the day and almost every day. So, if you are having change in mood or you are abnormal behavior for few times of the day, it is okay. But if it is lasting for long time and it is happening every day, then you can say patient is in depression or in distress, and it is influenced by the circumstances and sustained for at least 2 weeks. Then patient has loss of interest or pleasure in activities that are normally pleasurable, like everybody is watching movie, but he is not like laughing and talking and discussing, but he is not taking any part in the discussion, neither he is smiling or laughing, then it is something abnormal. Decrease energy or increase fatigability. These are the symptoms which are associated with the depression. In additional symptoms, the following list should be present to give a total of the list 4. Loss of confidence and self-esteem, unreasonable feelings of self-reproach or excessive and inappropriate guilt, recurrent thoughts of death or suicide or suicidal behavior, Complaints or evidence of diminished ability to think or concentrate, suggest indecisiveness or vacillation. Like this type of patient cannot concentrate in reading or talking to someone or discussing on some issues. They frequently change their decision. Okay, if they are going for a movie, suddenly they will say, no, no, I am not coming, I am lying down at home, something like that. Then change in psychomotor activity like agitation, getting angry, getting aggressive, sleep disturbances, and change in appetite, not able to eat. Sometimes too much of eating is also a sign of depression, and this is reciprocated on their weight. Indicators of depression in terminally ill are psychological problem symptoms as we saw earlier. Dysphoria means abnormal mood changes, depressed mood, sadness, tearfulness, frequently crying in any issue. Normal talk also gives them makes them cry. Lack of pleasure, hopelessness, helplessness, worthlessness, social withdrawal. They do not mix up with the people. They feel there is a constant feeling of guilty that I have done something wrong in my life, that is why I am suffering, and suicidal ideas. Other indicators are intractable pain or other symptoms. Sometimes patient has pain without any reason. Of course, all cancer patient does have pain, and even if their pain is treated by proper dosage of analgesia or medicine, they still keep on complaining about some other pain, or their pain fluctuates, their intensity also fluctuates. So, this type of pain is called intractable pain. You are not able to identify or point out from where it is arising and what causes it. Then excessive somatic preoccupation, disproportionate disability. Sometimes they are not able to do many things, not able to read, not able to cook, not able to do the simple course of the life. Poor cooperation or refusal of the treatment, hopelessness, aversion, lack of interest on the part of clinician. They do not listen to doctor, they do not follow their advice. Treatment with the corticosteroid, interferon or similar agents, history related indicator. Some few patients are on long term steroids or interferon, which is one of the drug again, can have this type of mood changes. Personal or family history of substance abuse, depression or bipolar illness, pancreatic cancer. These are the high risk group who are likely to have depression, and one should look for depression in this type of patient. Assessing suicidal thoughts in terminally ill patients. Examine patient's reasons for wanting to end his or her life. Sometimes patients do say this thing openly to the family member or doctor that I want to die. So, you try to probe, try to find out what is the reason behind it. Explore the meanings of patient desire to die. Assess pain and symptom control. If untreated or undertreated pain contributing to desire to, sometimes cancer pain is so severe, and if it is not treated properly, undertreated or not treated, then patient wants to die because of this pain also. Are untreated or undertreated symptoms contributing desire to die? Sometimes few symptoms in cancer patient, suppose like nausea, vomiting. If they are that is not treated, patient is not able to eat properly, and if he is not able to eat, he is not able to enjoy life, he does not have energy, then he wants to die. So, pain and symptom management is very important part of palliative care. Are fears about the dying process contributing to the desire to die? Sometimes patient knows that he is suffering from cancer, it is advanced stage of cancer and he is likely to die. So, he has that fear of death, that how that death will be, what type of suffering he will undergo, how he will face the death. All these questions, if not answered or not given proper counseling, can lead to the desire to die. Is the patient experiencing side effects from the medication that can be ameliorated? As I said, side effect of long term use of steroid and many other medication can have this type of depressive episodes. So, one has to evaluate this patient thoroughly about the type of medicine he is taking, and this type of medicine can be stopped if this type of symptoms like symptoms of dying or suicidal tendencies are existing. Review patient social support. Has there been a recent loss, conflict or rejection? Evaluate the social history. Sometime he is abandoned by the family member, by his own children, by his own wife or something like that. Sometimes there is a death in near one in family. Are there new fears about abandonment, rejection or financial burden? Is he worried about all such issues? With whom has patient spoken about his or her plan? Whether patient has discussed his future plan or his problems with family member, friends or with doctor. How do these persons feel about patient's plan? Assess, sometimes he has discussed, but family member has not given attention to it. They have just neglected, and this type of person feels isolated, that there is nobody to listen to his problem and to solve it. Are there any new neurological sign or symptoms? Sometimes cancer has spread to brain or spinal cord or some nervous tissue, which can lead to this type of behavior. Does patient know about his disease, his status, stage of disease, its consequences? Sometimes unknown fear is also a topic, a cause for suicidal tendency. When patient does not know about the diagnosis and he keeps on suffering, he is feeling weak, he is having lots of pain. So, he does not know why he is having such thing when he does not know the diagnosis that he is suffering from cancer. Is the patient judgment distorted by hopelessness and other symptoms of the depression? Assess psychological condition. Does the patient have untreated or undertreated anxiety, depression, panic disorder, delirium? So, all these psychological symptoms should be evaluated. How is the patient dealing with issues of loss of control, dependency, uncertainty and grief? Once patient cancer advances, he becomes more or less dependent to family member or other people around, and this loss of control over the situation, about the family decisions and family get together and dependency and grief, they can lead to depression. You have to also evaluate his regional background, his spiritual background, his thinking process about the nature as whole, universe as whole, and how he feels about it, that can help you diagnose his depression and help you to counsel the patient in this matter. There is a difference between grief and depression. Suppose your one near and dear one of your family member pass away, you will be in grief for a while, for a few days. But if it goes on for months and days and months and many months, then it can turn into depression. So, grief is patient experience feelings, emotion and behaviors that result from a particular loss, Of course, if you are in grief, you will be sad, you will not talk to anyone, you will not go out, you will eat less, you might have some loss of sleep, that is grief. Patients experience feelings, emotion and behavior that fulfill criteria for a major psychiatry disorder. Distress is usually generalized to all facets, but when this grief becomes part of your life, your day to day activity, it goes on for many days, weeks and months, then it is called depression. Almost all terminally ill patients experience grief, but only a minority develop full blown affective disorders requiring treatment. So, patient is in terminal phase, he is likely to feel sad, grief, but major depression occurs into 1 to 53% of the patient. Patient usually cope with distress on their own. If they are in grief, they can cope up with it. After few hours or after a day or two, they will attain their normalcy, get involved there with their routine, talk to people. This is what generally happens when we lose somebody in friends or family. But medical or psychiatry intervention is usually necessary when it is a depression. Then patient may require some medication and psychiatry evaluation. Patients experience somatic distress, loss of usual patterns of behavior, agitation, sleep and appetite disturbance and decreased concentration and social withdrawal. But along with this, if a person is depressed, he is likely to have hopelessness, helplessness and worthlessness. He feels that I am not worth of anything, and there is a feeling of guilt and there is a suicidal tendency. Grief is associated with disease progression, but depression can happen at any stage of the disease. Depression can happen with first stage, right at the diagnosis also, or at the advanced stage of the disease. And pain is the major risk factor which can cause depression. If pain is not relieved, it is a major risk factor for causing depression. Patient retain capacity for pleasure, and in depression patient does not enjoy anything. In grief, patient is depressed, sad, but suppose one a good friend comes and takes him out and chit chats with him or discuss something very funny with him, he is likely to come out of it and likely to enjoy the life. Grief is in wave form, it comes, goes, and depression is constant, it remains throughout for many days, weeks and months. Patient express passive wishes for death, sometimes just passing remark, I want to die, but here the feeling is intense, repeated expression or persistent ideas or thoughts about committing suicide. Then patients are able to look forward to the future. If once he comes out of the grief, he will have future plan, he will try to lead the normal life, but here there is no future plan and no normal life. After depression, we will come talk about the anxiety. There is a hospital anxiety depression scale to measure the level of the anxiety. Then there is a geriatric anxiety inventory, and for pediatric patient also we have a pediatric anxiety scale. This is the hospital anxiety and depression scale. Here few sentences are written what patient feels, and he has to mark it this feeling is for the most of the time, for lot of the time, occasionally or not at all. So, various feelings like I feel tense or wound up, second is I still enjoy the things I used to enjoy, I get a sort of frightened feeling as if something awful is about to happen in my life, I feel cheerful, I feel depressed, I can sit at ease and feel relaxed, and so many feelings are described. and at the end patient has to tick mark whether it is always occasionally or more frequently, and then there is a total score. If the score is 0 to 7, it is normal. If it is 8 to 10, there is a borderline anxiety, and if it is 11 to 21, it is a abnormal anxiety. Then this patient needs treatment. This is again geriatric anxiety scale used in the geriatric population. Various questions are given and one has to sum up the total and come out with a score which will be able to identify anxiety in the geriatric population. This is about children in pediatric population. Parent has to fill up whether his child felt like something awful might happen, feels nervous, scared, worried, and here there is a score of never, almost never, sometimes, often, and almost always, and you come out with the total score, and accordingly there will be diagnosis of the anxiety in children. This is again another score inventory, and here you have to write, say whether it is not at all, whether it is little bit present, somewhat present, or very much present, and the description of the situation is I feel calm, I feel secure, I feel tense, I feel strained, I am at ease, I am upset, and many other things. So, early identification of the symptoms, whether it is depression, anxiety, or distress, can help. You can help your patients by early identification, by proper evaluation. Here you have to evaluate his own background as well as his social background, family support, and many more things, and by initiating proper treatment for the same. So, early identification of symptoms of psychological distress, depression, and anxiety in terminally ill patient is utmost essential for proper management of such patient for optimum palliation both psychologically as well as for physical symptoms. Increase attention to diagnosis of psychological distress, anxiety, and depression can further improve the coping mechanism of terminal. So, if you treat this anxiety and depression, patient can cope well with his disease and with his treatment and its side effect. Thank you very much.